So thanks for joining us today. I am here with Dr. Alessia Moulton-Perkins and Dr. Jessie Goff. They are the co-director and director, respectively, of Neurodiverse Online, which is an assessment service. Both of our speakers today are clinical psychologists, and Dr. Moulton-Perkins is also a BABCP accredited CBT therapist. So we've got a lot of experience in the room today. We're going to speak for about 35 to 40 minutes, and then we're going to take some questions. And while I've got your attention, this is just a quick plug for next month's event, which is going to be with Dr. Varun Anand. He's spoken with us before, and he'll be talking about physical activity. So the title is Physical Activity for Long-Term Conditions. He's actually a BSLM doctor, so he's very well trained and experienced talking about that subject. So we'd love to see you then too. The link will be going out in the digest shortly. Okay, so Dr. Goff, would you like to kick us off?
Yeah, sure. I'll just start presenting, and then when we can see the slides. How's that looking? Can you see that?
That looks great, thanks.
Super. Perfect. So we are going to talk about, hopefully, enhancing health outcomes for patients with ADHD and autism today. And I am Dr. Jess Goff, and we are both, Alicia and I are both co-directors. I think maybe one of us had written director, one of us had written co-director of our small business called Neurodiverse Online. And we specialise in assessing and treating people who think they might be neurodivergent. So that could be ADHD, autism, tics, Tourette's, dyslexia, those kind of conditions really, or a combination of the above. My background, I'm obviously trained as a clinical psychologist. In the NHS, I worked for a long time, mainly in CAMS, child and adolescent mental health, but more specifically in a child and family neurodevelopmental team. I've done a few other bits and pieces, obviously, along the way. I've got a few different interests. I've worked in child forensic services, in eating disorders. There's a lot of kind of crossover, obviously, between different services as well. And Alicia, I'll let you introduce yourself.
Yeah, so I'm Alicia. I work with Jess in our small clinic, and I also work at the Oxford Institute of Clinical Psychology Training and Research, which is a collaboration with Oxford Health NHS Foundation Trust. So I train clinical psychologists there and supervise them on the research and teach, etc. So my background is mainly with adults and neurodevelopmental conditions. So I used to work at the Brighton Neurodevelopmental Service there in adult ADHD and tics and Tourette's mainly. And that was before I went over and worked in academia and then in private practice.
Okay. Okay, so we've got some aims for our session today. So we're going to be thinking about ways to enhance patient care by better identifying and treating adults and children who have ADHD and autism. Our talk's split into 4 kind of sections. I'm going to present the first couple of sections, and then Swap and Alicia will do the last 2. So we're going to look at a bit of an overview of the current healthcare context for neurodivergent individuals. We're going to think about kind of how we identify and where we refer people and the process of diagnosis for autism and ADHD. Then we're going to review the treatment options and think about adaptations in primary care clinics. So hopefully the end of the talk will be more relevant to our audience, but we'll be thinking about how this is impactful for you as GPs all the way through as well. Okay, so just thinking a little bit about the context. So there is some policy to be aware of. There's a national autism strategy for England, which states that we want to aim to reduce health inequalities by improving early access in relation to autism, reducing diagnostic waiting times, and improving diagnostic pathways. So that's what we're all looking to do in theory. And it also suggests that we should have mandatory training in learning disabilities and autism for all healthcare professionals, which I think is interesting because that probably isn't always the case. The audience may feel that that's not always in place. In relation to ADHD, there isn't a policy document at the moment, but there is an NHS England ADHD task force, which was launched in 2024. And the aim is to think about improving care for those with ADHD. And that task force is aiming to publish findings this summer. So hopefully we will hear more about what they want us to do and what NHS England is suggesting for us soon. In terms of the context, I'm sure you've experienced this in your clinics. We certainly have in our service, that the demand for ADHD and autism assessment has kind of risen. Anecdotally, I would say people would say potentially since the pandemic, but also probably more gradually over the last kind of 15 to 20 years. So therefore, understandably, the NHS has suggested that there's a need for kind of an improved pathway to meet demand and provision and provide adequate support. A little bit of research here was done with surveying GPs and found that nearly 40% of GPs said that they'd had no formal autism training. This was 2017, so it's a little while ago, but at that point in time. And that most GPs who did feel confident knowing about autism, that was linked to their personal experiences. So kind of anecdotal examples around family members, friends, that experience rather than through their kind of professional training. GPs in this study identified barriers as there not being available kind of support for families and individuals who are seeking assessment and treatment, not having clarity on referral pathways, and long waiting times, which I'm sure we're all pretty familiar with. If you've ever had anybody come and ask for an autism or an ADHD referral for assessment, certainly we hear, because we're a private service, people then come to us because of their long waiting times in their local area. This is just a sort of infographic to kind of illustrate what the process might be for some people who are seeking kind of ADHD assessment or treatment. I think we could say it's probably fairly similar for autism. I'm not going to describe it all, but essentially it shows that people may come to the NHS, they may then kind of segue off to kind of private services, they may want to kind of come back into the NHS for kind of treatment of their ADHD, they may seek support through kind of third sector organisations. And this is really kind of variable across up and down the country, isn't it? The pathway is not clear and straightforward for us as professionals or for our patients. And I think it's important for us to think about with you guys, because as GPs, you are the gatekeepers in this process. You are the front line where people come and ask often for the first time about this process of referral for assessment and treatment. We're going to think a little bit about the epidemiology of autism. I'm sure you're all pretty familiar with this, but the prevalence in adults, probably about 1% or so in the general population, and then maybe about 3% in children. This is people who've been diagnosed. As I'm sure you're aware, there's quite a lot of significant comorbidity with other disorders, ADHD being the most common in children, anxiety and also depression, and some other things that people may present with in clinic, which it might be worth kind of bearing in mind autism in this context. Of those children who are diagnosed with ARFID, avoidant restrictive feeding food intake disorder, between 12 and 33% of those will also be autistic. So if a family are coming in and talking about concerns they've got about their child's eating difficulties, and the same also goes for eating disorders more generally, you might be wanting to wonder about whether the child might also be autistic. The same for gender dysphoria. In a big study that Baron Cohen did, 24% of gender diverse people were found to be autistic. That is a big proportion, isn't it? So again, anybody coming who is non-binary, who's trans, who's thinking about those kind of issues, that is also something to be bearing in mind, really. Might they be on the autistic spectrum? Physical health conditions also more common in autism than in the general population, including sleep problems, sensory impairments, allergies, autoimmune disorders, obesity. So those are also things to be kind of bearing in mind. And when people are coming to see you for those kind of difficulties, could we be circling back and might there be an underlying neurodevelopmental condition that's driving some of the problems that you're seeing in clinic? ADHD, the prevalence is slightly higher than autism in the general population, those people who've been diagnosed. maybe about 5 to 7% in children and about 2 to 4% in adults. And again, a really high level there of kind of comorbidity, most frequently substance misuse, but lots of comorbidity with anxiety, low mood, other neurodevelopmental conditions. There's a big overlap with autism, dyslexia, dyspraxia, things like that. For you guys, ADHD and autism in medics, we're all part of the general population, obviously, aren't we? We're not immune as healthcare professionals from having a diagnosis or maybe being on some diagnostic spectrum. In terms of ADHD, there was a study looking at doctors who sought help for their mental health. And they found that 35% of those doctors, so these are doctors who are already saying that they're struggling, scored for ADHD on the ASRS screening questionnaire. So that's a big proportion of doctors who might be struggling with their mental health, who are potentially meeting criteria, who may be meeting criteria for ADHD. And obviously, of those doctors seeking help, there was a lot of coexisting mental health disorders. In terms of autism, probably rates in general practice are similar to they are in the general population. 1% of GP responders are autistic. And I've just made a note there about Autistic Doctors International, and it's a peer support group for doctors. So if anybody listening is autistic, or anybody who has a colleague who might be, they might be interested in kind of finding out more about that peer support group. I think it's also worth mentioning underdiagnosis of both autism and ADHD. I'm sure this is something that you're all familiar with. Probably in the older adult population, there's an underdiagnosis of both ADHD and autism, and in women, girls, and non-binary individuals. For older people, this is probably because our understanding and of the kind of the nuance of presentations has changed certainly over the last 20 odd years that I've been in practice, and I'm sure over the last 50, 60, 70 years that older adults have been alive. I think we're better now at picking up difficulties that would have been explained by, kind of naughty behaviour or bad behaviour in school when some of those older adults were much younger. And the assessment, the diagnostic criteria were originally designed, and a lot of the research was done on boys and men. So typically, women and girls have not so obviously fitted into those diagnostic criteria. And I think that has led to the kind of the underdiagnosis of women and girls, which hopefully is shifting now. I think that feels like there is a kind of tide change. We're certainly seeing a lot more women and parents of girls coming for assessment than we would have done 20 years ago. I think I was also going to say there that we often see people, women and girls coming who've had other diagnoses. So that will be something else to look out for in clinic. Somebody coming perhaps with a diagnosis of anxiety, borderline personality disorder, EUPD, trauma, PTSD. So sometimes people who are seeking kind of help, who've maybe tried cognitive behavior therapy, perhaps they've tried antidepressants, they're finding that the medication isn't as effective. So again, that might be another kind of time when that might flag up a kind of query for you about autism or ADHD, especially in women. This slide's about health outcomes in autism. And I guess the main take-home message is that children with autism in this study were found to be 11 times more likely to have poorer health than children without autism. So you're also going to see people coming to clinic who may not yet be diagnosed with other physical health conditions, complaints. So this is thinking a little bit about what the importance is of kind of early intervention in autism. Psychosocial interventions can have a significant impact on kind of outcomes, improving outcomes, specifically for children and young people. If we think about the support that might be put in place in the school or for adults in the workplace, so helping people to stay in work can be really important. Also just about self-understanding for the individual, understanding in the kind of wider family, in the social context about what's kind of driving somebody's behaviour. And these things can have a big impact on self-esteem and mental health and quality of life. And therefore, potentially how often they're presenting to you as a GP with other kind of mental health or physical complaints. So we've just kind of flagged up there that GPs play an essential role in primary care, because you are often seeing our patients, our clients, for all sorts of kind of other reasons. And if we can get in early in terms of intervention, we can make a significant kind of impact for these children, young people, and adults. This is a big population study in Denmark, looking at the mortality rates for children and adults with ADHD. And they found that there was twice the risk of death for people who had a diagnosis of ADHD, which is quite sobering, I think. And this is mainly driven by more accidents and injuries. So this is probably linked to the kind of impulsivity, hyperactivity domain for ADHD. Certainly we hear this anecdotally as well in clinic, that lots of people engaging in risk-taking behaviours, really. Whether that might be risky sports, driving too fast, getting drunk, putting themselves in dangerous situations, as well as the things that are mentioned here in the Young et al. Study: delinquency, criminal behaviour, substance misuse, unplanned or early pregnancy, challenges in educational work. So we may be seeing these clients for a number of reasons in our services. And knowing that if we do intervene, we can also have a big impact, maybe actually on someone's life expectancy. So this slide is just showing the results of a meta-analysis, which looked at medicated versus unmedicated individuals with ADHD. So we can see hugely improved outcomes in terms of number of accidents and injuries for those who are medicated, criminality, substance use disorders, suicidality, and traumatic brain injury. So this really highlights, I suppose, that for you as the frontline kind of workers, meeting people who may or may not meet the criteria for a diagnosis of ADHD, this could have kind of huge kind of social and societal kind of impact if we can swiftly identify these people and we can treat them effectively. So let's think a little bit about identification, referral, and diagnosis. I'm sure you're probably all pretty familiar with this, so I'm not going to describe it all in detail. In terms of ADHD, there are 18 criteria. There are 9 inattentive symptoms potentially of ADHD, and adults need to have 5 or more, and children need to have 6 or more. Those are the inattentive symptoms. And the hyperactive impulsive ones, again, 5 or more for adults, 6 or more for children. And it's worth saying there are 3 subtypes of ADHD. You can have combined, so both inattentive and hyperactive, or inattentive or hyperactive. So those are the 3 subtypes. So you don't need to have 5 or more in both of the different subsets of criteria, just 5 or more in one, or 6 or more as a child. We see more inattentive probably presentations in adults, and probably more of the hyperactive impulsive in children, just because of the developmental trajectory. Autism, there are 3 core A criteria as it's defined in the DSM: social emotional difficulties, non-verbal behavior, and developing and maintaining and understanding relationships. So you have to have all 3 of those for a diagnosis of autism, and only 2 out of the 4 B criteria, which I've listed here. It's also important to say, I've moved on, but we need to think about impairment as well. There needs to be a level of impairment, significant impairment, for a diagnosis of either ADHD or autism, and also evidence that there is some symptoms in childhood or in early kind of development. We can't always get all of those criteria appearing in childhood, but we would be wanting to check. And I think you as GPs, if someone was coming saying, for example, they thought they might have ADHD or they might have autism, a quick question about, is there any evidence that that was kind of around when they were younger? Because sometimes there can be a bereavement, for example, a recent bereavement, which could impact on someone's attention and concentration difficulties, or losing their job, or divorce, or other kind of significant life events. And we're wanting to know that that may have exacerbated symptoms of ADHD, for example. Is there evidence that there was some sort of struggling with these difficulties at an earlier point in life as well? In terms of screening tools, here are a couple of free screening tools that you might want to use for adults who may have ADHD. the ASRS, which is quite quick and easy to administer. It's only a few questions. And for children, the SNAP-4, which mirrors those 9, 9, 18 diagnostic criteria for ADHD. So just asking the parents to endorse, how strongly do they endorse each of the different criteria. Thinking about identification and the sort of referral process for ADHD, NICE suggests that it's important that we recognise these things early in various settings, including school and healthcare, and that teachers and health professionals should be trained to identify signs of ADHD. I'm not sure that they always are, but they should be, according to NICE, so that's good for us to know. And that we should refer on to a specialist service for assessment. And it's also worth kind of thinking about that transition, those transition times from children's services to adult services. If we're thinking about young people who might have ADHD, they're likely to have difficulties with being organised, with forgetting things, with keeping appointments, with administration. So this could be a time where they might slip off the list. They might no longer kind of be seen by child and adolescent services, and they may not do the kind of requisite steps to make sure that they're then taken on by the adult services. So as a GP, you might be wanting to think about how you can support them in that time of transition, especially perhaps if parents have been managing their appointments and their medication up to that point. For autism, NICE recommends as a screening tool the AQ10. It's nice and straightforward. It's only 10 questions. And a score of 6 or above suggests that somebody should be referred, or they could be referred for an autism assessment. There isn't a NICE recommended screener for children and young people, but the ASSQ is a free tool that we might recommend. So you could have a look at that and see if you thought that would be useful. In terms of recognition of autism in a GP appointment, you might be these are things which might flag up potential questions about whether a child's autistic. If they're not meeting their developmental milestones, if a parent's coming and asking about that, if they're mentioning persistent difficulties in social interaction, communication, or repetitive behaviour. NICE suggests you should involve parents in a discussion. Well, you probably would, wouldn't you, if it was a young person? And it's also worth recognising that autism might present differently depending on age, gender, and other coexisting conditions. So like somebody who's autistic but also has ADHD, sometimes those very different symptoms kind of almost balance each other out to a certain extent. So thinking about those things when we're trying to identify whether someone needs to be referred for further assessment. NICE suggests that you need to refer to a specialist multidisciplinary autism team, ideally, and to consider urgent referrals if there are significant concerns about a child's safety or well-being. So to escalate those referrals if possible. And we have a little online screener, which you could take now if you wanted to, or you could have a look at yourself later. On our website, we have some tests. Test yourself for kind of ADHD or autism, and you can get those results emailed to yourself. And or you could refer clients to this. We know that a lot of clients that we see in our service have done quite a lot of kind of prior research. They've looked at other kind of websites. They've done a kind of pre-screening kind of tests. So it might be useful for you guys to be able to refer them to a trusted place where they can investigate their symptoms a little bit more in detail. And I believe that might be where I'm leaving off. So I'm going to stop sharing my screen and I'm going to let you share yours, Alicia.
Super. Okay, so I'm going to take over talking about the treatment and management of autism and ADHD. So the treatments for ADHD in children are different according to how young the child is. So children younger than 5 should not be offered medication routinely for ADHD. Behavioural interventions are the first line. Children who are above the age of 5 can be offered medication, but it should be combined with a complete support package and behavioural interventions with the family or caregivers, and this is according to NICE. For adults, medication tends to be a bit more of a first line treatment. Of course, this would be initiated and titrated in specialist services until and if a shared care arrangement is organised. And they might be sort of treated with medications like methylphenidate, but I'm not going to go into the details of those medications because I'm not a medic, and you can read in NICE guidelines exactly which ones are recommended. Non-pharmacological interventions, such as psychoeducation or CBT, are very useful to offer to patients who prefer not to take medication, or maybe have had difficulties with it or experience a non-optimal response. So coming back to shared care, so of course, NICE recommend that shared care needs to be arranged between the patient, the ADHD specialist, and the GP. But of course, not all primary care networks, not all GPs engage in shared care. As I understand it, it's optional. If that's the case, then the patient needs to remain under the specialist in the specialist team. And I suppose some of the concerns that primary care clinicians have voiced around taking over shared care is around having to manage controlled drugs and the risk of potential misuse and diversion. And that's not an empty worry. There is actually evidence to suggest that there is the potential for diversion and selling of these medications on the street. So, for example, in a study of students by Willens et al., between 16 and 29% of the students who had a prescription for their ADHD had been in the past, at some point in their lives, asked to give, sell, or trade their medications. Other students might be looking to use this as a study aid or as a recreational drug. And it's adolescents and young adults who are really most at risk of this. If we're thinking about non-pharmacological interventions for children, so for under 5, medication is not indicated. Group parent training programs are really the way to go. And children above 5, that's also a good idea. Though, of course, above 5, they have the option of medication. But whatever is decided, it should always be a holistic package, and they should not be offered medication really ideally alone. There should be other support, psychological supports for the family and the young person. In adults, they should be offered non-pharmacological treatment as well. If they've made an informed choice not to have medication, or they've had difficulty adhering to it, or they can have it in combination. But the only tricky thing is, as we know, that even the specialist neurobehavioral services or neurodevelopmental services for adults, I think only about a third of them actually offer adapted CBT for ADHD, and generic counsellors or clinical psychologists who don't have specialist training in this area may not be adapting their therapies for adults with ADHD. So there's a big gap there, unfortunately. Autism in children and young people, depending, of course, on if they have a comorbid learning difficulty and intellectual disability. Often there are indirect interventions which are carried out with family and caregivers, and especially if there is challenging behaviour. And sometimes there might be direct interventions offered for the core features of autism, such as social communication difficulties. Speech and language therapists might become involved, or coexisting difficulties like anxiety. In adults, very similar picture, really. You can have therapies that are adapted for autism, or especially if there are intellectual disabilities, there'd be indirect interventions. So let's come now to the last part of our presentation, which is all about what can you do as GPs in your own clinic run, but also maybe in the wider context of your GP surgery. So there was a really lovely survey done by Bryce et al. Of autistic adults, and they asked them what did they want from their healthcare service. How did they want healthcare to be organised? And there were three themes. sensory environment, the service context, and clinicians' knowledge and communication. And together, if those adaptations are put into place, health outcomes should be improved. So let's take each in turn now. So autistic adults said that they want their sensory environment to be considered. So they would like rooms with smaller numbers of people. So your waiting room, ideally there would be a quiet side room or some area where there's not lots of people and not lots of light and noise. Now, this would also be helpful for people with ADHD because they can be highly distractible. And unfortunately, we don't have a similar survey to Bryce et al., who surveyed autistic adults. We don't have a similar one for ADHD. So I'm going to extrapolate a little bit for each particular area for what people with ADHD might appreciate. So the National Autistic Society made some further specific recommendations. They said it's really important just to ask the client what adjustments they would like. So an autistic person might appreciate being able to bring in a comfort item into the consultation with them, whatever that object is. It might help with their sensory regulation, being able to use their senses to emotionally regulate. And think about the room that you're in. How much clutter is there? Which room have you booked for that consultation with the patient? Are you wearing any perfume? Are there any strong smells in the environment? How are the seats arranged? Because all of these sensory aspects of the environment could be distressing or for the autistic person. And actually, if you manage those aspects, this is also probably going to be helpful for somebody with ADHD as well, because it will reduce those sensory distractions. And we do know that there are sensory processing differences as well in ADHD anyway. You can also consider having little sort of fidget toys available. Again, that's helpful for the ADHD person just as much as the autistic person. And then coming on to the service context. So autistic adults said that they want longer appointments and fewer of them. And they would like appointments to be offered remotely, ideally. And if the clinician is well prepared for the appointment with their clinical and historical information to hand, autistic adults really, really appreciate that. So they have to reduce the amount of repetition in telling their story to each new clinician. Having an easily identifiable and accessible location. And for example, in specialist services, they often send out in the appointment letter like a photo of the clinic and the front, the door that they have to go into and that sort of thing, because that helps with the predictability of the appointment for the autistic person. They really often appreciate that. Or having it on your website, a photograph of the clinic and what the waiting room looks like. And the waiting, it really helps if you have shorter waiting times if possible and provide support for those appointments. And ADHD patients may benefit from text message reminders and also easier ways of booking their appointments, such as online booking. So what do autistic patients want in terms of their actual clinicians, their GPs, and other primary care healthcare workers? Well, they'd like their clinicians to be knowledgeable and to communicate well. So they want us to understand what autism is, and they would like to have a familiar, easily identifiable clinician. So ideally not changing each time they come to the GP surgery, changing who they see. Of course, we recognise some of these things are more achievable than others, but this is the ideal anyway. And opportunities to ask questions. And the National Autistic Society have added some more very specific things about how you speak to your patient. So because we know that autism is associated sometimes with slower processing speed, and this is even amongst high functioning adults with autism, it's a good idea to offer information relatively slowly, offer a pen and paper so the person can write things down to help their processing, break down your questions into smaller units. And don't use metaphorical, figurative language or jargon. Try to reduce the amount of abstract language you use and use more concrete, real life examples. Leave time for the patient to respond when you've asked a question, and use clear, direct questions rather than open-ended ones. So sort of more straightforward questioning. Summarize, if you can, the appointment in writing afterwards. And don't forget to ask the patient what they would find helpful, because they might have their own particular useful suggestions. And remember that each autistic person is different, as is each person with ADHD. Although we do have the diagnostic criteria, there are 1,001 ways that that criteria can come together in a diagnosis. So when you're taking your history from your patient and you're listening to what they're saying, be aware that you might get back some quite concrete or literal interpretation of your questions with an autistic person. And if you are administering a screening tool or questionnaire, make sure it's validated in this particular population. Don't assume that your client can understand, identify, and talk about their emotions or physical sensations. We know that autism is associated with interoceptive differences, so they might not be able to report accurately how they're feeling. And don't assume, if the person isn't maintaining eye contact or their facial expression is quite neutral, don't assume that they're not engaged in the appointment. That might be just an aspect of their autism. And if they do need to fidget or stim, so repetitive movements, that doesn't necessarily mean that they're not paying attention. It actually might be helping them to pay attention. And if they do become overwhelmed and shut down and become silent, that can be a sign that the autistic person has reached their limit of stress and they need some time out, basically. So even very articulate, high functioning individuals, may also experience these things. And so not making assumptions, I suppose, is a good message. And then the last infographic here, which is from Doherty's 2023 paper, just adds a nice reminder that we mustn't forget the emotional needs of our patients. And they were saying that it's really important for acceptance and empathy, that alongside all those sort of more systems level interventions. And there's also the National Autistic Society. I'm not sure if it's the NAS or the Royal College of GPs, but there is some nice guidance out there for patients themselves on how to make the most of their medical appointments. So it suggests to patients things like, if they can, book an early appointment, off peak times, book a double appointment if their surgery offers that option. Maybe they might visit the clinic beforehand with their carer or friend or supporter. And they might benefit from a summary after the appointment. And for you as GPs, there's some resources as well. So as I understand it, there is a GP with extended roles in ADHD, which is something you might be interested in for your future career development. And there is a neurodiversity special interest group with the Royal College of GPs. So lots of places to pursue your interest if this is one of your passions. So that's the end of our formal presentation, and it's open to questions or comments. And I think Ellie's managing the chat here. Anything come up for us, Ellie?
Yeah, that's great, thank you. So Dr. David Church, who's attending today, said that he found it was surprising that so many GPs are not trained in ASD and ADHD. As he was in medical school in the 80s, he said he went to Leeds. Quite a bit's changed since, but he says it might be why so many people ask us, so many patients ask doctors on arrival to Aberystwyth Uni. I guess Dr. Church, you might be working there.
Yeah, actually, this is hopefully changed now. It's actually a statutory requirement that all healthcare professionals at least receive some e-learning in autism and LD. So, as a very minimum, we should all be having something. I think it's the Oliver McGowan training after a very sad case of a young man that died after, unfortunately, a care that was substandard because they didn't understand his needs around autism.
Dr. Church also added that unfortunately there's no local service for them. So
Ah,
I think that's quite an
right.
important point that we might want to discuss. I don't know whether any of
Yeah.
the GPs would like to chip in the chat maybe about whether they have a local service.
As in a
Yeah.
local specialist assessment service that you can then refer on to.
I presume so, yeah.
Goodness. Yeah. Yes, I know that there are massive waiting lists, but yeah, and so there's David Church now. Yes, please go ahead.
Yes, we don't have an interested person within the adult mental health team. I very well remember some years ago, but I'm not aware that it's changed much since. That it took we had a child who was seen for an assessment by the LD team, and the mother, obviously, having been asked all the questions, then came back to us as the GPs and said, "Well, all that applies to my husband as well." So we sent a referral off to the husband, and it took 2 visits to the clinic for them to discover that the husband was over 16, and that didn't go down very well.
And then he wasn't able to be seen.
That's right. Yes. He's over 16. That's the end of it. You can have him back, sort of thing, which was dreadful.
Yeah, a lot of our adult clients who come to us obviously privately in our little organization, they have often identified their potential autism or ADHD through an assessment of their child or their siblings' children or something like that. And then they think, oh, but I thought all of that was really normal. I do all of those things. Oh, interesting. And then go away and have a read about it. I heard that ADHD, in fact, is as heritable as height, which I thought was really interesting. Because we often talk about that in families, don't we? Oh, you're going to be really tall because your uncles are really tall, or that sort of thing. So we can all look around in our families if we can see anybody who we think might be ticking those boxes. Might need to take a close look at ourselves as well.
Well, perhaps we should rethink what we thought was normal, because I've just done the 2 tests online, the screening tests from your website, and I've been invited for an assessment for both.
Well, feel free to email our administrator, David.
I'm in a different country, so maybe not. I don't know. I could travel over, but and I think it maybe does. I think it maybe is inherited too, in terms of our approach, either genetically or through learning, because it would affect how we teach our own children, wouldn't it?
David, did you have a question about what patients want?
Well, I think all the patients, the most of the statements that were up there for what these patients want, I think most patients would answer exactly the same. Although I have come across some patients who are not able to cope with the IT, and I've even come across some patients who can't cope with phone calls. So they can only cope with coming into the surgery, which is sort of the opposite of what you might think of somebody who has difficulties in social circumstances. You might think they cope better with an IT solution. They don't always.
Yeah, and I think that just underlines the importance of asking the patient and not making assumptions that although the survey found that many people with autism wanted remote consultations, that won't be all. Some would prefer that individual in-person contact. Yes.
Could I ask, when you receive, let's say, a referral or some sort of referral from where the patient has come from a GP, is there a common thing that you kind of wish the GP had done differently or said differently, or about maybe expectations for the patient, or could they have more feedback with
Yeah, I think if it's particularly ADHD, I think it's really helpful that early on there is a conversation about, you know, if they have the vaguest interest in medication, they need to check with their GP whether the GP will, let's assume they are diagnosed and it's confirmed and they want medication. and they cannot get treatment in the NHS locally because the waiting lists are so long. So therefore they decide to go privately. Will the GP consider, once they are stabilised on their medication, will they consider shared care? And that conversation, or support them with doing like the sharing the health record, because you need to do a cardiac screen, doesn't necessarily mean it's an ECG, but so you know, the implications, the longer term implications. Sometimes patients have unrealistic expectations of what they're going to get.
Right.
You know, they might think, oh, I'll go and get a private diagnosis because I jumped the 4-year waiting list in the NHS, and then I'll be able to go to my GP and I'll get medication. It's not as simple as that. Yeah.
I'm thinking about children and families, and I would say some feedback that I get from children and families about GP appointments, and they also from school, is that people can present very differently in a clinical appointment than they might do in their own home. So sometimes children can actually sit really still and kind of quietly in the GP surgery, not all, but at home or outside of school, they're kind of all over the place, and the behaviour is kind of really, really obvious. Or they can maintain eye contact, they can have conversation in clinic with a GP, but in other situations that maybe are not one-on-one, and when they're not being expected to do that, the autistic traits might be kind of much more obvious. So sometimes people who are seeking a private kind of diagnosis will say, my GP didn't believe me because I've learned these surface level social skills. I can get by in that kind of a situation, but there's a huge kind of emotional toll kind of to performing at that level, which for a neurotypical person would just feel like quite an easy, comfortable kind of situation to be in. So I suppose, quite often with the adults we see, because they're professional people, maybe they're paying for a private assessment, so they're holding down a well-paid job. They might not be so obviously kind of autistic or obviously ADHD when you meet them. You might think, how could somebody who has ADHD, be running a kind of company or be a CEO or be a university lecturer or something like that? But behind the scenes, their life is kind of chaos. It's the dumpster fire that you kind of can't see, but the professional front is very kind of calm and coherent. So actually asking for those examples of lived experience, which can be quite shameful for people to admit to, I think, that can be quite telling sometimes.
Yeah, I'm just thinking about my wife's office when I go in there, actually. Now you mention it. No, she's just fine. Well, so if I just ask one last question, I'm quite curious in terms of our NASGP membership. We've got obviously thousands of GP locums who are members, and I'm wondering, because often we come across members and the reason they're locuming is because they were a partner or were a salaried GP, and that rigidity and was just far too stressful for them, so they've come out of that, and now with locuming they found a better work-life balance. So I'm wondering if there's a difference in the percentage of GPs who might have neurodiversity. If there's a sort of an increased.
Yes, very possibly self-selecting, that we choose the careers and the settings which suit our particular profiles. Right. So yeah.
But on that, on GPs with neurodiversity, I mean, I'm familiar with the term, people considering their neurodiversity as a superpower, and I'm wondering if there are any if there are GPs who have neurodiversity, if there are particular aspects of being a GP or a doctor that lends itself really well to that neurodiverse approach.
I think there could be, couldn't there?
Yes.
I mean, we're going to talk in sort of big generalities, sweeping generalities here.
Yeah.
But autistic people can often be very good at memorizing information, have fantastic kind of attention to detail. So as a GP, they might be spotting things that other people wouldn't spot. They might have a really kind of thorough process that they can kind of follow to identify the cause of a problem, maybe something a bit kind of nebulous that other people haven't got to the bottom of. Thinking about people who step outside being a partner in a practice and work as a locum, I imagine that would work better. If you're somebody who is very detail orientated and very thorough, that might not fit with the kind of the constraints of kind of being a partner in a practice, might it? On On the flip side, people with ADHD are often quite creative, are often entrepreneurs, risk takers, people who do things a bit differently in life, often have really good people skills. So they might have been attracted to being a GP because you're meeting lots of people and you're doing a lot of kind of, work there where social communication can be really important, can't it?
Yeah.
But again, might be happy to be outside of the kind of system, being a locum, doing things in their own way, and not feel the need to kind of be inside the system, as it were. So I could see there's definite possibilities for both those conditions, isn't there, and strengths that might apply in both situations.
I think that what your description there, Jess, very much to me describes what all the GP locums do. It's that sort we often refer to that second pair of eyes, a second opinion. They're taking a different approach, and they can lend an extra different layer of nuance to a consultation because they've taken a different approach to their regular GP. I mean, that's part of seeing multiple people anyway. But that's that is interesting. Thank you.
Right, well, we're coming up on time, and it doesn't seem like there's any more questions left, so there's not much left for me to do but to thank the speakers today. I'm sure everybody got a lot out of this talk. We've really enjoyed hosting you on this kind of issue that is becoming increasingly important and visible in the press. Yeah, lots of thanks. So thank you from Jane and thank you from Dr. Evans as well.
Super. Well, thanks very much for inviting us. And yeah, goodbye, everybody. Hope you have a good clinic this afternoon if you're working. And I suppose we'll switch off the recorder now, yeah, and say goodbye to everyone.
Thanks a lot. Lovely to meet you all. Enjoy the sunshine if you get to see some of it this afternoon.